Hello, my name is Vaikunthan Rajaratnam. I'm a hand surgeon based in Singapore, and today we're going to talk about the role of surgery in the management of patients with post-stroke spasticity. The only disclosure I would like to make is I have a philosophical bias towards patient-reported and perceived outcomes uh, as important in measuring our treatment modalities as opposed to more objective and physician-centered measurements of outcome. We are aware of the impact of stroke on patients. And I think it is important to return to this Engels model on the biopsychosocial impact of disorders on patients. And I think we have to look at it more holistically on the impact on just not on the biological aspects of the strokes spasticity, but also the psychological and social economic impact. And then hopefully at the end of this Congress, we will look at it in a more holistic fashion. We are really fortunate in this Congress to have both Sheng Li and Gerard Francisco who are participating and talking about the pathophysiology of the spasticity as we understand it today. And I think cognitive neuroscience has a lot to add to this, and understanding the total pathophysiology of spasticity and its impact on evolution and on rehabilitation is important as we move towards looking at treating patients with this severe pathology. For us to treat patients with post-stroke spasticity, one of the important concepts to understand is human volition. What makes an individual want to do a particular motor action? And this is the ability to generate that motor action and the subjective emotions and thoughts that goes towards production of that motor action, and the goal that is intended, the outcome, and how this affects the patient's whole experience on conducting a particular motor action after a stroke and its impact on spasticity. It is important to understand that post-stroke there is significant changes that occurs as part of the rehabilitation and the recovery that occurs in stroke. There's extensive rewiring and new synapses that are being formed as a result of neuronal inactivity from the damaged area in the brain. This is important in the management in terms of the surgery or other modalities that we are using to intervene and to rehabilitate, while at the same time understanding the normal recovery that occurs with stroke. So the framework as provided for by von Monacaux on the spontaneous recovery in stroke and how the neuronal pathways and recovery occurs following the index event in the production of stroke, the diakinesis reversal, the compensatory and the cortical reorganization that occurs as part of the recovery process, and how the rehabilitation that occurs through recruitment and retraining of the neuronal fibers is important in our holistic approach towards the management. How surgery impacts this is important, especially with the role of neurectomy and contralateral C7, which we will discuss later. To understand the impact of spasticity on movement, it is important to understand cognitive load. With the increase in spasticity, it's become very difficult to perform a particular motor action if volition is preserved. And this results in the lack of reward for a particular activity, and this would interfere with rehabilitation. Reduction of spasticity helps in the execution, and it is worthwhile knowing that sometimes if the rewards are satisfactory, even an inefficient energy consumption to produce that motor action is worthwhile. Most of us surgeons are familiar with lower motor neuron lesion and the role of plasticity, which is the process in which new dendrites, new connections are formed to compensate for the loss of function. And this has got a significant role even in stroke. And this has to be taken into consideration when we look at treatment modalities for the management of post-stroke spasticity. One of the important things in neuroplasticity is the concept of Hebbian learning, which is repeated actions performed in the rehabilitation helps in the formation of new dendrites and new synapses, which facilitates learning. And it is important, therefore, to be able to provide an environment that allows for this synaptic efficiency to occur through structural changes in the rehabilitative and in the retraining process. There's been a recent interest in the use of surgical intervention, especially in the use of selective neurectomies in managing spasticity of particular sets of muscles. This is a targeted approach towards reducing the spasticity and its effect through the increase in the reflex pathway to help in the retraining and rehabilitation of patients to improve outcomes. There are various terminologies being used. In this summary slide, we see the terminologies for the reduction of spasticity through the division of nerves. So highly selective and hyperselective motor neurotomy and neurectomies are the types of surgery that we do to reduce the amount of electrical stimulation that is coming to the motor, producing the spasticity. But note also that it's just not the spasticity, but through the division of nerves, there is a reduction in the gamma reflex and its antecedent effects in the central spinal cord and the central nervous system by hyperstimulation of the adjacent neurons, producing hyperexcitability in other areas apart from the motors that have been reduced. And this is an important aspect of the plasticity and the rewiring that occurs in the restorative phase of post-stroke spasticity. The recent controlled trials that were done in China on the role of contralateral C7 division and transfer to the paralyzed limb has shown some positive results. And these are early stages. There are more research that needs to be done. I think this study has shown the role of reducing the spasticity by removing a central portion of the axons that are producing the effect of spasticity in that limb and transferring that the normal contralateral side that we use commonly in lower motor neuron lesion to this distal portion, allowing the architecture for rewiring to occur in the brain. This is poorly understood at the moment, but I think this is an area that there will be future research in, as it allows for the natural rehabilitation and the restoration of function post-stroke spasticity. I think some of the important things that have occurred recently with post-stroke spasticity is to look at the future on how things are moving. I think the role of robotics are going to help in the rehabilitation to allow for the natural process of restoration of function through rewiring centrally, and the role how surgery will play in the reduction of spasticity to facilitate this rewiring. I think it's also important that we need to measure the impact of the disease on the patient's life, the psychosocial impact, through instruments that help us measure them accurately and simply and comprehensively. I think there will be more role for the contralateral C7 transfers for the future as we see more control studies coming out from this. So what's the take-home message? I think things are still early as far as surgery is concerned in the management of post-stroke spasticity. We need more work and we need more control studies. It will be difficult to perform randomized control studies in surgical management for post-stroke spasticity, but I think well-conducted observational studies will provide some answers. I think the evolution of the management strategies will continue to occur. And one of the important aspects to measure outcome will be a simpler assessment tools that takes into account the patient's subjective feeling and experiences following intervention and rehabilitation. And I think this Congress has started the conversation between various professionals in the multidiscipline team approach towards the management of stroke spasticity. I think this is an important approach towards post-stroke spasticity, and we would like to welcome all participants to hopefully the 2022 Second World Congress on Post-Stroke Spasticity. Thank you.